All right, well, good afternoon, everyone. My name is Erin, and we are here in our week 7 of this Project Echo course on Introduction to Palliative Care in Humanitarian Settings with a focus in Kenya. And we're really excited to be at the end of the course. You guys have been really committed to the course. I know the last few weeks we had to delay this last class, but thanks for joining into our last session. I've been helping to facilitate this course, but we also have a few of our other faculty members on the call today. So I'll just let them quickly introduce themselves. And then if you wanted to put your name and where you're working in the chat, that's also a really nice way for us to get to know and continue to develop our professional relationships. So Vilma, would you like to say hi to the group? I know it's the morning in Canada.
Hello, so you might hear screams behind me. Hi, everybody. I'm Vilma. And yes, I'm near Toronto in Canada, and I work for a community hospice.
Thank you. Thanks for being with us. I know we've been a little bit delayed in this last class, but thanks for being here for the last call. Kayla, Dr. Kayla, do you want to say hello to the team?
Good morning, everybody. I'm just driving. My name's Kayla Wolofsky. I'm a physician at Toronto General Hospital in Toronto as well.
Thanks for being with us today. And I don't see any other faculty. We do have Dr. Omar with us, and he's going to be leading the, oh, sorry, Ali. Ali Hamis, do you want to introduce yourself? Sorry, Ali.
Yeah, thank you, Erin. I'm very happy to see my colleagues today. My name is Omar Abdihamid. Currently, I'm in the Dadaab Refugee Camp, working for humanitarian setting in this camp.
Thank you. Thanks so much. So we'll get right to the topic. Today, we're going to be talking about the neglected needs of refugees in Kenya. And we're really honored to have Dr. Omar with us today. So I think, oh, there we are. Nice to see you. Let me just introduce Dr. Omar, and then I'll pass I need to make you a host, sorry. I'll pass the microphone over to you. Okay, so Dr. Omar is with us today. Many of you met him maybe a few months ago now, but Dr. Omar is a clinical oncologist working in Nairobi as well as Garissa Cancer Center. He has a master's degree in clinical oncology from a university in China, and he mainly specializes in adult cancers, including breast cancer, cervical, head and neck, esophageal, stomach, among other cancers. He's really passionate about cancer care, as we know from the previous times we've been on the call with him, as well as equity in low and middle income countries. He advocates for culturally based cancer care, affordability, patient education, as well as access to treatment. He has published many articles, and he's a scientific writer and editor for different cancer journals. And just recently, he is a fellow of the 2023 ASCO IDEA Award and the winner of the ASCO Voices 2022. Which has been really exciting. And it is one of the reasons, and I know you have been very patient with us, is one of the reasons we couldn't have the call at the end of June or at the beginning of June, because Dr. Omar was traveling. But we're really great. Where are you today? Are you in Nairobi? We can't hear you. Oh, yeah.
Yes. Can you hear me okay? And
yeah, we can hear you now. Are you in Nairobi?
No, I'm actually yes, I am in Nairobi. I was in Garissa yesterday running some clinics, but happy to be here. And my background looks good for people who are waking up, who are really requiring some coffee on the road. I always like putting different backgrounds every time, because I'm always on the road. So
well,
welcome. Get started, Erin?
Yeah, welcome, and we'll hand it over to you. There's a few people that have just put their introductions into the call. We have a health promotion supervisor from Dagahali. We have someone from MSF working in Dadaab. So keep putting your introductions in. It also helps our speakers know the audience well. So welcome.
Perfect. So I know I've been given 20 minutes. I don't think I'll even need 20 minutes. I'll keep it short. So this is the topic. It's neglected cancer care needs among the refugees. And my background is a bit busy and a bit loud, so don't mind if you hear some funny sounds. Okay, good. Yes, so the agenda for today is, can I say from the onset, this was a very difficult, I know when I say it's difficult, it's not such a difficult topic, but I feel like it's more of a political issues and a lot of different countries, more like, it's very hard to weave the cancer care needs without forgetting the political part and the government part and jurisdictions and everything. So I tried to really make it a bit, weaving everything together. I'll talk about what is a refugee. A lot of people throw that word around. We need to know who actually is a refugee. We're going to talk about the global perspectives of refugees and their cancer care needs and the gaps and opportunities in their cancer care needs, and specifically bring it home a bit to Hagardere and Dagahle and Kenya. What is the situation like for refugees? And maybe this is not an official recommendation on solutions, but part of the literature summary that I've gotten, which are directed towards how to really improve the cancer care among the nomadic community, among the refugees. So definition: a refugee is someone who has been forced to flee his or her country because of a persecution, or war, or violence. I think that's and again, this is the UNHCR definition. So I really wanted it to be official and formal, which is the UN body that takes care of High Commission for Refugees. Another word that really kind of mixes up with the refugee is IDP, internally displaced person, and this is defined again by the UNHCR as someone who has been forced to flee their home but never crossed an international border. So these are people who are internally displaced, and the distinction from a refugee is the moving to another territorial lines. Globally, the trends are really shocking. 108 million people described to be refugees from the year 20, again from the website of UNHCR, by this report called Global Trends in Displacement among Refugees. The trends at a glance here, it is 108 million people forcibly displaced worldwide. And out of that, 76% are hosted in low and middle income countries, being Kenya being one of them. And again, across the border, due to the recent, Syria and Ukraine and all that, you can see also there are around 3.6 million people in Turkey. And among that, 62 are IDPs and 5.4 are asylum seekers. And generally, globally, 1 in 6 person is displaced. So the report further projects that, these are data that, again, from the UNHCR, talking about, the around 108 people were forcibly displaced as a result of conflict. And recently, even in Sudan, as we are following the development from there, the refugees numbers keep growing. Adding to all this is because of the climate disasters, apart from wars and all that people are running away from. There's also a very unique category of actually refugees called climate refugees. These are people who have been forced out of their inhabitants because of climate change, extreme conditions of climate change, such as extreme weather, droughts, and all that. So locally, I got this from the website as well. Kenya, there's around roughly 500,000 refugees, and most of them are in Dadaab, Kakuma, and urban areas. And there are a lot of people who probably know more data regarding this aspect of population. And, this could be even underreported, in my opinion. And among that, Somalis are the majority, followed by South Sudanese, Democratic Republic of Congo. And if you look at the demographics, the shocking part that I could not believe was 76% of all these people are women and children, and refugee status also being majority of them compared to asylum seekers. So globally, the incidence. So I wanted just to step back from after that background, because there's the neglected cancer care needs among these people is what we want to focus on. But before we do that, I wanted also to bring a bit of a background for globally what the cancer incidence landscape is. In 2022, which is a bit not updated, there are around 10 million people who died from cancer. Out of that, globally, you can see breast is the most common, prostate, lung cancer, colorectal in that demographic histogram. Number of cancers closer home in Africa, breast being the most common, followed by cervical. And this is also cancer site at an anatomical site among both sexes. So you can see really the patterns are a bit different when you even bring it closer home to Kenya again. In terms of, all these numbers that you're seeing, the funny thing and the unfortunate part is that around 70% of all these cancers actually occur in least developed part of the world. As you can see, this world map, most of these dots are in the global south. So, and why is that? Because even though the majority of cancer incidents in the global south, 90% of LMICs, that is low and middle income countries, do not have access to radiotherapy, which is one of the essential ways to treat cancer. And 5% of the global resource in terms of research funding and all that is really not spent in LMICs. And by 2040, the global demand for cancer chemotherapy will increase from 10 million to 15 million. Again, this will be felt much more in low and middle income countries. So really, there is a lot of inequity in our own backyard, okay? And half of the world population access to the full range of essential health services. Why? Because there's income and and a country's GDP that are different from each other. There's a political stabilities. There's the climate change. There's so many things, and there's a lot of disparities and discrimination in terms of access to this life-saving treatment based on ethnicity, race, gender, and sexual orientation. So closer home to Kenya, let's talk about the data among the refugees in Kenya. Can I say, I really tried to look for data and I could not find any, correct me if I'm wrong, but maybe there are people who are more versed with the landscape of generally healthcare needs among the refugees, but I could not really find any cancer-related data in Kenya. All I'm seeing is just these communicable diseases, cholera, skeletal fibrosis, acute respiratory infections among refugees, especially in children, which is a very good data. But my point here is there's literally no data, among refugees in Kenya pertaining cancer care needs or even the incidence. Really, driving the point of statistical invisibility of this special population. So this is really a global call of advocacy on the cancer care needs among refugees. Dr. Andre Ilbawi is the I think medical officer for WHO, and he has a background of surgical oncology. He wrote this piece, really trying to call on to the world that really access will be improved for refugees. Recently, my colleague and friend, Professor Nazik Hamad, wrote this from our home country. She's based in Canada, but I was talking about the current conflict of Sudan and its ripple effect on the region. So barriers to cancer care among refugees really is multifaceted. A lot of issues going on, and which are very unique and multifaceted. These include cultural differences, languages, fear of the procedures of even these patients, history of trauma, social trauma, someone being uprooted from their own, locality and and where they grew up and coming to a whole different country, lack of understanding of the medical infrastructure in their new home. Really, it's a lot of multifaceted and different factors. So I pulled up this from online, from PubMed, talking about the refugees across the world on how they really how they really feel on preventive healthcare and the access of cancer care needs. And this was among the Bosnians, Iraqis, and the Somali refugees, a comparative qualitative study of refugee health on the preventive health and breast screening. And the solution and the findings of this paper was that similarities across the participants, the common denominator was the fear of pain and diagnosis, modesty. Remember, there's this cultural-based care that is required, but when you bring different people who are all from different backgrounds and pushed together in one place under the status of refugee, really these are very heterogeneous people, in terms of their culture. So there's modesty part of it on access to such certain maybe invasive procedures. There's fear of even the pain and the diagnosis from a cultural perspective. And all this needs to be considered when dealing with this special population. So among the UNHCR, or even the global worldwide programs, I came across this initiative, which is very good initiative in the US called Building Bridges Program. It was started in 2014 using a community health worker model for Texas. And it provided refugees residing in Texas for more of cancer screening services and education among this refugee community. So the paper that really led to that was uptake of cancer screening among the multi-ethnic refugees population in North Texas. Again, showing similar findings on the previous, compared to, the previous paper about the women in Bosnia and Somalia. So the paper really recommended the need to really weave into the sensitivity of the care for this population by really trying to introduce, multilingual, multicultural, and translators, videos, graphics that they can really understand in terms of anatomical based cancers for them to for people to improve the cancer care needs uptake. So I think I've mentioned this study. Refugee groups really respond differently because they're a heterogeneous group. For example, there's a study by Samuel et al. That was done among the Somalis and the Cambodian. They found that the Somalis and the Cambodian were less likely to be screened, especially for those invasive procedures than the Vietnamese and the Cambodian counterparts. In this study, also 19.4% of the refugee Somali women somehow accepted the cervical cancer screening. If it was really done in a manner that conforms to their culture and in a way that it could be explained probably in a mother tongue they understand, for these cancer screening services. So now that we talked about the gaps, these are some of the key considerations for screening among the immigrants and in refugee camps. And I'm going to go into anatomical based different cancers. I'll talk about breast cancer, cervical cancer, and down the line to GI cancer. Okay, cancers remain to be a higher prevalence in refugee population despite the paucity of data. Majority of the unique cancer risks in refugees and immigrants originate from probably infections, and because they live in a setting that really does not have a well optimized care. Over 2.2 million of the new cases worldwide in 2018 were actually attributed to cancer. And all these really happening in low and middle income countries and displaced population. So a study on cancer mortality about immigrants in the United States also showed again and marked the infection background of these cancers, notably nasopharyngeal cancers, Kaposi sarcoma on the background of HIV, stomach cancer on the background of H. pylori, liver cancer on the background of hepatitis, and many more. Helicobacter pylori and hepatitis B were cancers that were mostly 92% infection attributable cancers worldwide. Now, can we talk about the subsets of breast cancer and how we can really help this population in terms of screening and uptake and even awareness? Okay, so this is immigrants. A study again from the US that showed immigrants from the United States undergo mammography at a lower rate than the US. I think this is a no-brainer given the access to facilities. These are people who are, domiciled in a particular area. They don't have insurance. They don't have health-seeking behavior. So this is really easy to understand on the lower uptake, even though they really need equally to non-immigrant population. Clinician and health therefore should spend more extra time and effort to tailor education to immigrants and refugees. Cervical cancer, it's especially important to perform pap smear screening on all the refugee patients. Let's say they moved from Africa or low and middle income country and they move to high income countries. These are people who have never gotten any cancer screening. So despite their old age, that's not to say that they should not be screened for cervical cancer, even though there are guidelines on which age to stop the screening because of lack of benefit. So yes, and then let's talk about liver cancer. Because remember, we talked about almost most of the cancers from Africa, or even 13% of the global cancer incidence related to an infectious background, hepatitis being one of them. So this is a very low-hanging fruit to really know. In fact, let's not even talk about the liver cancer. Can we even know the hepatitis incidence either B or C and among these refugees. And this is a meta-analysis that actually showed when you use a simple alpha-fetoprotein, this is a blood test marker for early HCC detection, in combination with an ultrasound, which is a non-invasive and easily available, if if funding was there for refugees, that it has actually, it can easily detect the liver cancer at a sensitivity almost 63%. So therefore, it's good to put this together rather than using it separately. I think we mentioned this. And then let's talk about the oral cancers. A lot of effort has been put into community health workers trying to really improve oral hygiene. And really, it's also good to do visual screening for oral cavity. And if there are obvious lesions that are very, very, easy to see, then they should be sent. These patients should be sent to higher tertiary care and to rule out cancer. Okay. Similar study that actually I did this oral, simple, reproducible, and less cost effective by just doing oral examination for 200,000 patients in India, and were followed up to 9 years, actually really reduced the mortality of oral squamous cell carcinoma mortality by 27%. So really, this is a low-hanging fruit that can be really availed to refugee communities or even patients at community level. And definitely telling people not to smoke tobacco and to not to eat, chew tobacco is also part of the counseling avenues that can be used. Esophageal cancer, which is a big disease in northern Kenya and even generally in Kenya, also should be a low-hanging fruit for screening for these patients. Symptoms patients usually come very late when they can really feel difficulty swallowing. And weight loss, because if they're not eating and they can't swallow anything, then they will easily lose weight. But this is a really, really devastating disease. And conversely, if it's really detected early by really doing endoscopy screening and people on the background of untreatable GERD, gastroesophageal reflux diseases, and acidity that doesn't go away, then it's also an easier disease to treat with a good outcome. But here is the key point. As early esophageal cancer typically causes no signs or symptoms. Remember, the esophagus is a luminal organ. And at some point, only when it's blocked halfway, that is the time when a person can really feel it. But the early mucosal cervices and lesions are very hard to detect, especially in the setting of refugee patients. Gastric cancer, this is a well-established H. pylori that we treat every day. It's a class 1 carcinogen actually, and it's responsible for 60 to 80% of all gastric cancers. So really, upscaling these patients that really are being treated for repetitive, H. pylori should be actually an index of suspicion for other cancers. I know I'm running out of time, but nasopharyngeal cancer is also very common cancer that's really we're seeing in a huge numbers also in northern Kenya, especially at Garissa Cancer Center. And this should be considered for high risk patients, especially those who have a positive family history and those who have recurrent nasal stuffing or even bleeding or even hearing loss or even issues to do with the vision, because there are a lot of nerves that really go through the back of your nose that control how you see the vision. Bladder cancer, not a very famous cancer for which can benefit from screening services, but I think this schistosoma hematobium is really common in some part of Kenya, and this can be tailored into patients who probably have presented with a blood in their urine, and maybe it's the setting of patients in the refugee camps and who keep complaining about blood urine should also be screened for bladder cancer. Lung cancer, and quite not a very good disease that can be screened in our setting because of its similarities with presentation symptoms when it comes to TB, and easily really gets misdiagnosed most of the time. But I think anyone who gets anti-TBs who's not improving should be further upscaled for care. So all these that I've talked about really have a public health implication, and the need for cultural and linguistically appropriate outreach programs, especially in refugee communities, is really timely and should be pursued further. World Refugee Day, just to remember, since the topic is about refugees, is June 20th, and people should really, in this talk, we should really think of in the next June 20th to really come up with a plan to really screen these cancer patients, refugee patients for cancer, and that should be a gift for their World Day. good news about Kenya and trying to integrate refugees into its citizens. This was the news that I pulled from the database of Kenya. I think the citizens and refugee website talks about this minority group called Pemba that were actually included as citizens and were granted citizenship. See the lady with her baby with her birth certificate. Takeaway message is that cancer care for refugees is actually feasible despite many naysayers, but it's a political matter. Remember, I started off by saying it's really hard to really split between the two. Political goodwill and political support under the UN, under the global collaborative effort between different countries is what is really needed. Early detection of cancer screening in the camps is really, really timely and should be pursued further, should be encouraged. More importantly, I said this is a group of people who are heterogeneous. They're from different countries. They have social trauma. They've been uprooted from their country. Their cultures is not the same. So should not be painted with one brush in terms of its their uptake into different types of cancers. And, different people who can really translate the disease into a language that they can understand is really important. So therefore, clinicians will maintain a high index of suspicion related to infectious diseases and environmental exposure that disproportionately affect immigrants and refugees. Health systems should be ready, especially the host countries, to avail programs for these refugees. Deficit in primary care and the bureaucratic clinical pathway and lack of referral systems from the refugee camps to tertiary care is really, really a big problem. And I think this is a low-hanging fruit that we can really explore to improve on their outcomes. We need to appreciate that this population have a trauma. They've been uprooted from their countries and where they belong. There's a forced migration because of either politics or climate change, and there's a need for sensitivity, and to understand where they're coming from and to also understand why they are not really open to cancer screening. Understanding that and then explaining that, I think will really help us improve in tailoring a tailored cancer screening services. And really, we need to invest in non-communicable diseases. This is a wake-up call to UNHCR. I know people invest a lot in communicable diseases, infections, and all that. While I do understand that those are very important because these are people in one confinement, and infectious disease might kill them faster than a non-communicable disease. But I think the future now is going to be management of non-communicable diseases like hypertension, diabetes, and cancer. Lastly, I wanted to put a plug into my center in Garissa Cancer Center, where we have all services, radiotherapy, chemotherapy, and since this is a bit near to the refugee camps in northern Kenya, really refer this patient to nearest cancer center. Okay, that's Garissa. There's also Nakuru Cancer Center, which is the second picture, and then there's Mombasa Cancer Center. All these are outside Nairobi centers, so to speak, so that there's no excuse in saying patient cannot be referred to the cancer center. This will be very cost effective. It will also be very easy for patients to be satisfied in getting a service closer to where they are. And really, there should be a collaborative research between these three centers regarding care of refugee patients. This is Garissa Cancer Center. It was launched early this year, even though it was operational from last year. That was the governor and the minister for health of Kenya and during the launch. These are the services available. We do have screening services there. We have mammograms, believe it or not. We have ultrasounds. We have radiotherapy machine, which are actually chemotherapy services, which are almost free, to be honest, compared to other service centers in Kenya, because this is provided by the Kenya Medical Supply Agency for free. And if this was a quote that you've been waiting for, it's bad to have cancer and it's worse to have cancer if you're poor, or I will even add if you are a refugee, to be honest. The gap between the rich and the poor, and I will add, and the refugee is really, really wide, and we really need to close that gap. Cancer does not have a face until it's yours or someone you know. That's the time it will really hit closer home. And if I was, since we're talking about refugees, I thought I'll end on a light note. This guy called Kainan, he's a Canadian Somali, and he was born he's a refugee. He immigrated to Canada. who works with UNHCR in improving access to healthcare needs among refugees. And this was his quote. He said, "If I was going to be free, I'll have to change my name." So you can imagine being a refugee is such a terrible tag. And I will direct you to his new song called Refugee. That's the gentle one I'm talking about. And where you live should really not determine if you live. And these are my references. And thank you very much for having me.
Thank you so much, Dr. Omar. I know we've been waiting to hear your perspective on this, and I think I'd love to open it up to questions. We don't often get a chance to have Dr. Omar in the room with us. So does anyone have a particular question or comment about the content that he's shared today? Just relating to access to cancer, the importance of screening. We've talked a lot in this course about inequality, and oftentimes it doesn't always feel right to really promote and provide palliative care when the inequalities feel like we should be doing something about that. We're trying to do both and at the same time. I think a lot of the cases that people have been sharing are where patients don't get screened. Patients get seen when they have very advanced cancer and they basically don't even get diagnosed. So I think it's hard. We need to promote both. We need to promote good quality care, good screening. Does anyone have any questions? Ali, do you have a question for Dr. Omar? Ali's been working in Dadaab for, I just found out, 18 years. No, sorry, 8 years, 8 years. And he's a clinical officer, used to work with MSF and IRC, but currently is working in a private facility. What are your thoughts on cancer care in the camps?
Yeah, thank you, Erin. I would like to ask a question to Dr. Omar about we have lack of referral system in refugee camps. In the Dadaab Refugee Camps, the referral system is very poor for palliative care patients. So is it possible we engage the government and palliative care centers on the UNHCR so that we can implement palliative care in the Dadaab? The Dadaab is the main center for refugees, both Degahli and Agadera and Ifo. So it could be possible if the government help us and the palliative care centers, the donors, they can look to implement the palliative care center in the Dadaab, so that the referral system for palliative care should be possible, that we can handle clients in the Dadaab. It's easier.
Yeah, Ali, I think this is a timely question, and maybe Erin can talk about the logistics of the IRC and UNHCR, what they're doing about. But honestly, I agree with you. I mean, this is just such a neglected disease among the refugees. It's like almost not a priority, so to speak. Yeah, everybody talks about infectious diseases, but I kid you not, if today there was a program that we went there, even on a voluntary basis, and we sample just one of the camps, I'm sure we'll see a lot of patients who just have lumps and bumps, and people who cannot, who have urine retention, people who have bleeding that cannot be explained by menstrual cycle, people who have diseases that don't go away, people who keep complaining about and acidity and all these kind of stuff, or even people who have obvious wounds on their faces and no one has even bothered to biopsy them. So I think referral systems are really important, and there's no excuse. Garissa and Dadaab is really like what? Maybe 1 hour on a rough patchy road, but if probably even much less than that. So we have seen 1 or 2 patients from the referral from the refugee camps, but really they're not many, and it's really difficult to help them sometimes because Kenyans, most of them have insurance. They are not in. They don't have ID, identification card. They don't have passport, Kenyan passport.
Did we lose Dr. Omar?
Yeah, I can't hear him either.
I think one of the interesting things, maybe his internet went out. I think one of the interesting things that has come up from this UNHCR training, of course, I think we've shared with all the participants that are all of our faculty, our volunteer, our program at the moment, we do this. We don't charge UNHCR for this kind of training. I think one of the really interesting things that has come out is that the referral system is really bad and everyone is really worried about what to do for these patients. And I think because we have such a big team, we have about 15 faculty members. We have you all now as participants. There's over 30 people that were registered for the course. I'm going to really challenge our group. Although, you know, the course is over today and you'll get your certificate and everything. I really want us as a group, because we're the first group. We're the first group that is really like, Dr. Omar has been working in Kenya for several years now, and he's also shocked that there's like nobody doing anything or paying attention to this at all. And it's almost like for such a time as this, I think that after this course, we really should get together. I mean, unfortunately, I probably will have to continue to be virtual, but we really need to come up with some really good ideas and find the right people and talk to the right people and identify that screening is really important, basic support for someone who possibly has cancer. And then, of course, if they can't guarantee treatment because of all the barriers and the cost, the cost ramifications for that, then we definitely need to have palliative care plans for these patients, because then pretty much we don't offer them anything. And I don't think that that is something that UNHCR would, we can't really prove it, like Dr. Omar said, because we don't have research, but the anecdotal evidence is very strong. And you guys are, through this program at least, like we can begin to report and record that it's dismal, like the situation is very dismal. So Dr. Omar is definitely going to be, hopefully, a very strong voice for refugees with cancer in Dadaab and in the region, especially now because we no longer have an excuse that they have to come to Nairobi. It's going to be slow, but I think, I'm just really hoping that we can meet the right people and talk to the right people, have really strong evidence, or be able to very confidently say there's no evidence at this point because nobody is investing in this. And we really want to begin to change the atmosphere for refugees. As you can see, I'm really passionate about this. So I'm going
Erin, if I may ask. Sorry to interrupt you. So let me ask you, because you can only speak for IRC. What is IRC doing in terms of services like this that we can really bring closer to the refugees? In terms of palliative care or early detection or even screening. It doesn't have to be the whole spectrum. In terms of treatment, you guys cannot even do much over there. But all we need is just three approach. That is early detection, maybe patient empowerment and education, and what is IRC doing about this?
So I can let Dr. Barbara share. I can share afterwards. She's the medical officer for IRC. Dr. Barbara, do you want to share a bit about what IRC is currently doing for cancer patients?
Thank you, Erin. Thank you, Dr. Omar, for the class. I missed the first bit of it, but I think I'll watch the recording just to see what I missed out on. All the issues that have been mentioned are true. We have challenges with early detection, except for a few, like maybe cervical cancer, but often even the ones that we're able to get biopsy, the results come back and they're really stuck because it really isn't anything you can do. We don't have the expertise, the equipment, or the drugs to manage these patients. And it's really painful for the patients themselves, but also quite hopeless and creates a lot of apathy among the staff that have to take care of these patients, not being able to help them in any way. So I have a few questions. Okay, so one is at the cancer center, one of the issues is cost, because even for those who, definitely all these chronic disease cases, NCD cases don't meet the criteria for referral by UNHCR. But there are a few patients who are able to facilitate their own movement to Garissa or other parts of the country to get access to the care that they need. However, this is just a small section of the population in the camps. Most people are destitute. They don't have the money for transport, or they may not have the money to pay for treatment when they get there. So what would be the cost implication for a patient, say, that we want to refer for diagnostics or even definitive management once we get a biopsy that has confirmed a malignant tumor? How much would they have to pay? Is it a minimal amount? You know, of course, majority of them, if not all of them, being not Kenyans, are not eligible for NHIS. So they would be paying out of pocket. So what kind of advice can we give some of these patients when they come seeking help? Because I don't have a lot of direct contact with the patients, but I often get cases of patients who come and, you know, they're stuck, they've been suffering for months or even years, and they want help, or they want some sort of support from IRC, and we are so limited in what we can do. So the cost for screening or diagnostics, the cost of treatment, you said it is minimal. Can we quantify, you know, how much that would be for the few who are able to do a self-referral? Because in that case, all that we need to do is to write a letter to the camp manager indicating that this patient is unwell and they need to travel for medical treatment, and they are able to get the movement pass and get to the other side. My other question is on
Dr. Barbara, can you hear me?
Yes, I can.
Hello. Erin, can you hear me? I think my my network just cut off. I don't know if you guys can hear me yet.
Yeah, we can hear you.
I can hear you.
Hello.
Yeah.
I think it's him who can't hear us.
So, Erin, if you can hear me.
Yeah.
So I was asked, Dr. Barbara asked me, yeah, what is the cost implication? I hope I'm audible now. My network was a bit off. So the cost implication really is quite cheaper compared to the standards of other centers. I mean, chemotherapy is basically free. They don't pay for anything. It's provided by the government for free. So that should tell you something. Secondly, radiotherapy is almost half the price of Nairobi. Okay. So it's something to do with, let's say, 3,000 Kenyan shilling. That's like, give or take, $30 per session. Where in Nairobi, it's $120 per session. Can you imagine? Mm-hmm. So I think if these patients are referred to our center, they don't pay any consultation fee in their first clinic visit. They get to see an oncologist. They get to see a whole team of doctors, nurses, palliative care nurse, you know, radiotherapy nurse, and everything. And it's all they just need to do is to come there on time so that they can be seen. And for radiotherapy, since they do not have the health insurance, or maybe they do not have cash, sometimes there are compassionate programs where the UNHCR people, maybe if they can have an MOU with the cancer center, then that will have been really something that can be pursued further. But as of now, really, I don't see a reason really to neglect a patient for treatment on the basis of cost, because chemo is literally free. I mean, it is free. They don't pay for everything.
What if a patient doesn't have an NHIF
and the first
card?
visit for them to come see an oncologist, I think it's free as well.
If someone doesn't have an
Erin,
NHIF.
You're on mute.
What happens when people don't have the NHIF card? Do you apply for it for them?
I think for some reason he can't hear us.
Yeah.
Although we're getting him very clearly. Yeah.
I think the reality is,
Dr. Barbara, can you, I hope I answered your question.
I think the reality is
yes.
maybe the timing, there's still a lot of barriers, it seems like, from UNHCR side. And I think that with the growth of the public cancer care system and the fact that there's actual facilities much, much closer now, maybe now is the time that we really do advocate for some sort of refugee cancer care program. Like, we know that UNHCR doesn't want to pay for care upfront because the care for non-communicable diseases is high. The cost is high because you have to treat people for longer periods of time, right? But maybe we've never also had an opportunity where the cancer facility has been so close and the resources are already there. So although we definitely, the historical reality is that we have not been able to refer people to cancer facilities because they don't meet the criteria. Maybe we also challenge UNHCR to re-look at the criteria because maybe the situation is different now. I don't know. But
yeah,
I definitely.
Yeah, go
Sorry,
ahead,
go
Dr.
ahead.
Barbara.
Yeah, I agree that there's the opportunity, and during we normally have periodic referral committee meetings where all the heads of programs of the different camps come together and discuss some of the challenges that we might be facing in referring patients. And one of them, of course, constantly comes up is the issue of referral for NCDs and particularly early stage diseases. Like, at times you can get a cervical cancer that's stage 1. This is someone who can make a full recovery, and the survival rate is really high, but because of that barrier, they're unable to access the care. So the opportunity is there, and I will call upon you, Erin, and Dr. Omar, and all the people in the palliative care fraternity to help us with lobbying UNHCR to revise their guidelines. I know that there are challenges with the funding that's available for these kinds of cases, and that's what limits the number of people or the types of cases that they accept for referral. But I think the more people, lend a voice to these patients and try to, support their plight and help them to get care, then we might get somewhere.
Yeah.
My other question was to Dr. Omar is about morphine. I know, Erin, we discussed that it's available morphine syrup in Kenyatta, and it's cost effective, but if we can get it somewhere closer. I know we are, as IRC, we're planning a visit to the hospital within next week. So is it available, and is there an opportunity for us to be able to access the syrup for our patients here through the Garissa Hospital or the Garissa Cancer Center? Yeah, and my final question is on GISADEP. I don't know if Dr. Omar is familiar with it, but there's a plan for the refugees to be integrated into the host community in Garissa County. It's something that's already happening in Kakuma. And what it does is it gives them some degree of autonomy. They're able to secure permits to work. They're able to secure even NHIF. I think a fraction of the population gets the premiums paid by UNHCR. And one of the plans that are in place for that proposal is to build a level 4 facility in the camp, in Dadaab. Yeah. So is there an opportunity there as well to maybe bring the care closer, even by bringing in oncologists, for example, or palliative care nurses to come to the camps, to that facility once it has been set up, so that they don't have to travel that distance, and they can, get, even if it's a consultation, without having to go all the way to Garissa, if there's an opportunity for that, because the county government is behind the project. Yeah, other than that, thank you guys so much. This has been a really enjoyable session and very informative. Thank you, Dr. Omar, for the work that you do, and congratulations on the opening of the center and for bringing this much needed care close to people who need it.
Yeah, thank you, Barbara. I think, sorry, my network has been really on and off. I don't know if you heard me when I was explaining. I was trying to answer your question about the cost effectiveness. Did you hear my answer, or do you want me to repeat, or are you okay?
Yeah, we were okay. I think we just talked about not being able to, what do you do when patients don't have NHIF? Do you have a separate, like a private stream where people go?
Yeah, so believe it or not, most of the patients actually do not even have NHIF, even the local citizens. So,
Yeah.
so what happens is for radiotherapy, we made it a compulsory so that we can improve the uptake of the insurance.
Yeah.
Because unless we do that, we'll not even try to even enroll on NHIF. And so now for radiotherapy, we made it a must. Chemo, we couldn't do that because chemo is free anyway. So even if they show up, they can still get the chemotherapy as long as they have indication for it. So I think in terms of cost effectiveness, that right there is no center in Kenya where that gives chemo for free. So it is really cost effective, and it's right near the border where it's right near the refugee camps. So really sending these patients, once you see them, the clinicians who are there, the nurses, should really, that the onus is on you guys. Just refer them here. We don't even have, they don't even have to pay on consultation fees. Will you believe that, Erin? They come, they show up, they get the service of an oncologist. There's a nurse, palliative care nurse, morphine. I heard you asking about morphine. It's plenty available in Garissa Cancer Center, even the hospital itself. It's free, and as the national guidelines, it's never sold in any public hospital. We even have medical social workers who can really navigate them through the system. So I think it's just the cutting the bureaucracy from the team in the camps and trying to have a communication with us is what you guys are required of. Mm-hmm. And I'm happy to see Duncan writing that they do early treatment screening for cervical cancer for all patients of reproductive, and they do even cryotherapy. Yeah. Well, Duncan, good job. But can I also tell you, please, once you do that, you've done a good job, but don't send that mother home or that lady home. Let her come to the clinic, maybe to Garissa, and that is not enough for a clean bill of health for her case, because we might need to see her. We might need to, maybe the other symptoms that she has. Just because it's an early lesion does not mean that she might not have something else going on. So she might get an opportunity to be screened and do a staging CT just to rule out what's going on, and further treatment, and even to explain to her what she has, and even explaining the biopsy. Remember, you did a cryotherapy, but I think since it is see and treat approach, which I accept, but and I know there are also no pathology services, someone that can really take a bit of a biopsy. Basically what I'm trying to say is try to also escalate her to the Garissa Cancer Center, so that she, in case she needs something else that she needs to know, or proper follow-up, she can be seen there. So that's a good job in F4, and I like that actually to continue to other centers.
Yeah, I think we are definitely going way over time because we haven't even had a chance to share the case. What does everyone want to do? Annalice, I see your hand is up. I know you haven't had a chance to share the case. Go ahead, Annalice.
Hi, Erin.
Yeah.
I think Dr. Omar has explained everything, and I'm glad to hear that he has mentioned so many cases that we normally come across in our camp. And we have really lost a lot of patients, especially with the esophageal cancer, which we just suspected because there was no investigation. And then my question is that Dr. Omari has suggested that patients should be referred to Garissa Cancer Center, and the investigation or the seeing oncology consultation is free, and maybe some other services which are a bit low with low cost. Yeah, they are maybe free. My question or suggestion is why can't he just maybe with a few team members come over to the camp and then have that free camp of screening of this our beneficiaries? Thank you.
Yeah, Annalise, I think that's a great suggestion. Yeah, but I think there are pathways on how to approach that. These are people, I'm sure they're in a specific administrative issues to go through.
We cannot come there with the name of Garissa Cancer Center without the approval of the county, maybe executive or the administration. So really, IRC and the UNHCR, you guys are such a big names. It's time for you guys to have a memorandum of understanding with the Garissa County, and we'll be happy to support the refugee community. You know, I mean, just going the formal pathway, I think, is the missing link at this time, at this point in time.
One of the things I wanted to propose, so normally our classes are just for 1 hour. So we obviously want to be sensitive to that. I can stay on the call for another 30 minutes. Annalice wants to present a case. If you do need to leave, obviously it's understandable. But one of the things from the final class I wanted to propose is actually we set up 2 different groups. From what I can hear over the last 2 months, is that access to morphine is not equitable in the camp. Some of the facilities get it, some of them don't. I would really love to be able to really identify what the major challenges are for that and come up with some solutions. And then the other one is this referral, the referral thing. So I thought if you guys are willing, I'm not really going anywhere. We're planning to be in Kenya for the next several years. So is there a way that we could meet even every few weeks and just actually try and solve some of these problems rather than continue? I mean, of course, we needed the environment to talk about this, right? We needed to be able to get together regularly to develop relationships and now share what are the real issues. Are you guys interested or willing to, for me, if I set up a few dates, it probably will be outside of Project Echo. But I do have a Zoom account, so I can continue to gather us. If I put together a list, if you're interested in signing up for one of these kind of working groups or working teams, where we maybe over the next 3, 4, 5 months really try and work on this really in a really effective way. Are you guys interested? If you're interested, raise your hand. Okay, so I know what I'll do is I'll communicate with people via email and also on our WhatsApp and see if some of the people that are really passionate we can continue to meet. It will be outside of the certificate and the course, but I think it will be really meaningful and it will hopefully create a lot of impact. Dr. Omar, what is the rest of your afternoon like? Do you need to go off the call now?
Yes, unfortunately, Erin. Okay. But the case,
okay, let me send it.
Yeah.
I'll send it to you, and then if you have some thoughts, it is an interesting case. The guy is married to a Kenyan. He's a Somali refugee, married to a Kenyan, so he actually had access to NHIF. So he came to Garissa, but because of I think it was because of the family's unawareness of what is cancer, how can you treat it, how can you do, he just came back to the refugee camp with no treatment. So he was treated palliatively due to patient choice. And it is really sad, super sad. But I'll send it to you. It's in a PowerPoint. And then if you have a few comments, I can pass it on to the team.
Wonderful. Yeah. So
okay, well, thank you.
Thank you for having me, Erin and the team, Annalice, Barbara, the whole team, colleagues from Canada, and everyone in the really front line trying to change lives and give hope. So I think the parting shot is that Garissa is near. I keep repeating, please send the patient. Those who are doing cryotherapy, kudos, like Duncan, good job. But please also escalate them to the cancer center, because that is not enough for someone probably who already has a cancer, because that's not a clean bill of health. They need probably a follow-up, and they need to be put into the system for further follow-up, because anything can come back. Any other person who probably have any lumps and bumps, and the clinicians have a high index of suspicion for possible malignancy, also, I think it's really fair to the patient if they can afford to really come to Garissa. And finally, to the UNHCR team and IRC, I think you guys should come pay a visit to the center so that you can put the face to whatever we're talking about, and see all the services that are available and how we can work together, and more so create probably an executive visit to the county authorities so that they can really see how you guys can work together.
Yeah.
So yeah, so thank you for having me.
Thanks so much. We'll see you around, Dr. Omar. All right, we will, if you do need to drop off, I am going to record the rest of this session, but please do stay. The case that we're going to share now, Annalice, one of our faculty members, is going to teach us. And I think it's a pretty common situation that we find ourselves in, where we have patients that have high symptom burdens, and our access or our ability to treat in the way we've been taught in medical school or nursing school, the barriers are just so high. So let me share my screen. Annalice, it's over to you. Sorry that it was a bit delayed, Annalice, but thank you. Thanks for being with the team.
Okay, thank you, Erin. Thank you, everybody. Good evening, good afternoon, good morning. This is a case of neglected cancer care needs for refugees in Kenya. Go ahead, Erin. These are some of the questions that I really wish that we respond to or we think about, and then maybe have solution to some of them, or if not all. I say, how best can the humanitarian agents ensure beneficiaries access specialized care with such a limited resource settings? Within such a limited resource setting, then how can the government and humanitarian agents work together to ensure the beneficiaries have equal benefits to quality health care? Then is there any way that such a cancer can be diagnosed without specialized investigation, where referrals are next to impossible? Then how best could we have managed this case and continuum care, putting the insecurity and infrastructure challenges in mind? Next, Erin. So the case is a patient diagnosed with the cancer of the stomach, male. Next, Erin. The treatment and significant investigation is that the patient presented at Garissa Referral Hospital with the epigastric and sternal regional pain. He frequented outpatient clinics with constipation alternating with diarrhea, bloating with distension, abdominal distension. Then that was in 2017. 2019, there was an intestinal obstruction diagnosed. Then a laparotomy was done, a mass was extracted, and patient felt some relief, returning home to Hagadera. In 2020, the same symptoms recurred, this time in a more severe form, and he was referred to Garissa, that is now by IRC, for review and management. Explorative laboratory against was performed, and a biopsy was taken. That was in February 2021. Next. Next, please. Okay. In August 2022, after the laparotomy in 2021, the patient felt some relief and then came back again to the camp. In August 2022, the patient was admitted with complete intestinal obstruction again at Garissa, and then another explorative laparotomy was performed. But on opening the abdomen, they realized that it was completely, a mass was completely occluding the intestinal pathway. And then that was suggestive that the cancer had spread. But they had not informed them of the biopsy results, which was taken sometimes in 2021. So A CT scan was performed and you confirmed the 4th stage cancer of the stomach. Next year. Next, okay. When the patient was, after opening now the 3rd time, the patient and the next of kin decided that it was now too much, and when they were informed of the stage of the illness or the prognosis, they decided that they rather go back home. Immediately after opening the abdomen and returning the patient from theater, they decided to come back to the camp, and they nursed the patient on using local herbs, and it resulted into septicemia and anemia because the patient was bleeding, the abdomen was distending day and night, and then when they learned of the palliative care from the community health workers and that is when now they decided to call for help. Next, Erin. So the holistic assessment was done, and the pain and the symptoms, including relevant treatment, was initiated. But during the visit of palliative care team, we just suggested that the patient was best to be cared for at the health facility. That was just to be brought in the hospital. Then the chief complaints at that time were vomiting blood, bloody diarrhea, unable to feed, abdominal distension, foul smelling, discharging, operative site, then general severe body pain, was general wasting, and then again swelling. You could see the face is wasting, but the body and the limbs are swelling. Then there was lack of sleep. He could not sleep. He was unable to sit or stand on own. Then he had severe septic shock actually on arrival. That is what the clinician or the physician had to observe. Then anemia due to disease cause and the poor medical care post-operatively. Next slide, please. So in assessment, we used the Edmonton Symptom Assessment System, where we scored the patient pain because the patient was in pain. The medication he was using was paracetamol to add again another load on the already metastatic process. Then tiredness, the patient was tired. He could not sit or stand on or even support himself. He was drowsy. Drowsiness was 2 because he could not sleep. He had nausea and he was vomiting at times. Then lack of appetite, he could not eat. When he eats, he feels the stomach is full, he cannot breathe well. Then shortness of breath because of the distension and the fluid was really exerting pressure on his breathing system. Then depression, we rated 9. He was depressed. He had so many factors in the home, and now to add on the disease. Anxiety, we rated him 7. Best wellness, we rated him 1 because he was not at best at all. Then other problems like constipation, he was constipated, he was not passing stool at times. When he passed, very little diarrhea, bloody diarrhea, then he was vomiting again. We rated him 10. That he scored 70 over 100. Next, Erin. Current treatment, the prior treatment he was managed by morphine injection 10 milligram BD for 3 days, then changed to syrup, which we had at least acquired from Nairobi Hospice. We gave him 10 milligram, that is 1 meal. Anytime he felt pain and he was discomfort, so we had to relieve the pain, the symptom. Then sepsis was treated by intravenous antibiotics, ceftriaxone 2 grams BD. For 10 days when fever could not subside, IV augmentin was started, 1.2 grams TDS. Then IV Lasix 80 milligram BD, aldaclone was 100 milligram OD administered for edema and ascites or CCF. And then anemia, blood transfusion of 4 units was transfused. He continued transemic, vitamin K was given, ferrous, all the treatment for improving or boosting the blood level was given. Then constipation was treated with lactulose, 10 mils PRN, frequently oral fluid intake. Next, Erin. The patient now is on home-based care, on antidiuretics. He gets IV DNS, small frequent oral fluids, positioning 2 hourly to prevent precious area sores, and then massaging is done. Change of pampers to avoid heat burn, because he cannot stand or support himself to open bowels. Then daily visit by CHW to take vitals check. Then 3 weekly for physiotherapists. Then 4 weekly visit by the palliative care and mental health nurse. And then need for psychosocial support and medication uptake monitor. Lab technicians 2 weekly for blood and urine samples. Normal take, and then we collect and bring to the lab for test. The patient, now that is the psychosocial and family concerns. The patient is married to 4 wives, 2 died, 1 divorced, and now with the youngest, with a total of 18 children, eldest being 45 years, married with 8 kids, and youngest 8 years. He's a pastoralist, successfully registered with family with the NHIF card, married a Kenyan national wife that resulted in him becoming a Kenyan citizen by marriage, despite other families being refugees. All his children access formal and religious education. None has formal employment. Some are drug addicts, which contributes to the depression status of the patient. NHIF account exhausted and no replacement option. He sold all his animals to cater for his hospital bills. Next. The patient is worried of what will become of his young kids now that the young ones are into addiction. Having exhausted the NHIF cover and not in position to make monthly payments, what happens to any of the beneficiaries of it? Family concerns about the large family care at the Kenyan and refugee family. Next. The spiritual concern, there is increased amount of stress due to family dynamics. Then the patient is worried about what will happen due to symptoms, concerns about the future. What will happen if he goes and leaves these children not in their sound minds? Next. Summary of the case. The pain management goal was use of morphine and lactulose and non-pharmacological therapy of warm massage. And psychosocial support goal was involvement of mental health care team to manage the addictive family members. Then there is nutrition goal, involvement of nutrition team in support with porridge, fortified flour, and milk. Then mobility goal, involvement of agents dealing with the persons with the disability. Before was the LWF, but now we have HI. Then the economical goal is to encourage qualified family members to seek employment from the agencies and support boost of existing small family business. Then maybe continue paying for the NHIF card. Fortunate enough, one of the son is employed by IRC as a community health worker, which is now at least boosting the income of the family. Next, Erin. So we go back to our questions. How best can the humanitarian agents ensure beneficiaries access specialized care within such a limited resource settings? Then how can the government and humanitarian agents work together to ensure the beneficiaries have equal benefits to quality health care? Then is there a way that such cancer can be diagnosed without specialized investigation where referral is next to impossible? Then how best could we have managed this case and the continuum care, putting the insecurity and infrastructure challenges in mind? Back to the class.
Thank you so much, Annalice.
Thank you.
I think this case is probably very similar to what many of you are facing, and I'm really interested. I'll put the questions into the chat. I'm interested what people's thoughts are. We talked about quite a bit of this. How do humanitarian agencies support patients like this? I think the reality is it's really difficult for them because of all the barriers to give good quality care, evidence-based best practices. We can't actually do that in the camp, which is really hard because I think many of us want to do what we've been trained to do. We want to give the best care that we can. And I think sometimes it's really challenging. Does anybody have any comments on this particular case? Ali,
Erin.
Yeah, go ahead.
I think Dr. Omar has given us a clue on about the question of the government and the humanitarian agents, how to go about it. So the ball is in Dr. Barbara's hand to link up with the UNHCR, and then maybe they can discuss and find way forward.
Yeah, definitely at the referral meeting. Sometimes when you already have, routine meetings in place, we begin talking about it there. I'm sure obviously they understand that during those meetings is when a lot of cases are brought to their attention. But I think if there's ways that even us at PallCHASE can support you, maybe with, a one-page document explaining a little bit or giving examples like this case. Obviously, I know from just speaking to many of you, the UNHCR budgets are reducing. So it is hard. Their hands are also kind of tied, but maybe the situation is a little bit different now than it was even 5 years ago or even 2 years ago. Seems like Dr. Omar will be a really good advocate for us as a group. Ali, how would you guys normally manage a case like this where the patient had some access to care, but then had a lot of symptoms? What would you do? Or how would you support the family?
Erin, you have to remember the aspect of principles of palliative care and the speak setting. We have to sit with the family, psychologically counseling and spiritual and support them, and also to do bereavement with them in case of the patient passed away. So in such scenario, you need to have to do a greeting rapport with them and have an introduction about their case, about the prognosis and the treatment. So in this case, you can understand how this patient was suffering the whole year, the last year, the last years, the years we have left. So always you are not supposed to tie. You have to assist them in palliative care support and give them psychosocial and spiritual support in such scenarios in our setup. In terms of treatment, you have to give them and you have to treat him, the patient, in a good manner way.
Does your private facility offer home visits? Obviously, it sounded like this patient really did want to just go home and be treated at home. Obviously, because of probably how old he was and just the reality that he began to understand that this was a very serious illness. Do you guys ever offer home visits?
Yeah, we offer home visits. Even several do home visits with Annalice. So we work hand in hand with analysis, and we used to do home visit at the home level. Yeah.
Yeah, I think it's really important. I'm not sure if there's anyone else on the call today from Red Cross or MSF, but I think part of the training is we want, although we don't have the answers and solutions to all the challenges and problems we talked about today, I think understanding that there are many patients that may want as much care as possible to be given at home. I think these are also some things that we can begin to talk to our supervisors about, or just with other NGOs that are working in the community, maybe with community health workers, that it is possible to give aspects of palliative care at home. You don't have to do palliative care only in the facility. And I think that sometimes it can be more cost effective to do that. It often makes patients feel more comfortable if their home setting is safe and clean. Yeah, sometimes that is what patients want. I know some situations patients don't want to be at home. So obviously we need to make sure we're doing what the patient desires are. But yeah, it sounded like definitely for this patient, he wanted to be treated at home as much as he could. All right. I think we talked about, yeah, the government. So Annalice right now with IRC is definitely a focal point for palliative care. She has the experience. She's accessed extra training to be certified in palliative care. I think what we can continue to do as a group is really advocate for people to actually be compensated for the advanced care that they're giving. People like Annalice and others who've been able to access training. Of course, our training is very short, but there are different opportunities in Kenya where you can access some specialized training in palliative care. We also, from an administrative point of view, should really advocate that people get compensated for that, or get new roles where they're possibly an advanced practice palliative care nurse, or someone managing a palliative care program, because you can't do palliative care really by yourself. I think that is what some of this program has identified. People like Annalice and Ali, who've been doing palliative care for many years, are eventually going to burn out. And eventually they are going to move on. I don't know, Annalice, how old you are, but eventually you are going to retire. And we need to have systems in place, especially in places like Dadaab, where the need is very high. So I think one of the things that we can challenge humanitarian agencies to do is to really consider some more leadership roles in terms of supporting patients with these advanced illnesses. And it's not easy, because I'm sure, like many other things, everyone is trying to look for more leadership opportunities. I know more funding went into the mental health teams recently, which has been great. But we also can continue to advocate for improving quality of life of patients with advanced disease. Because we know, I think the reality is, we know that many of them are not going to be returning, especially in our setting, to Somalia. we know that many people will be living in this region for many years to come. So I think, yeah, I'm really proud of the work that has been done in Dadaab and with the team at IRC and MSF and Red Cross. And I'm really excited about the next few months and to see what we as a team can do as we support you kind of virtually, but also find ways to really support locally in Garissa and in Dadaab. Does anyone, Michael, do you want to share some thoughts? Or Dennis? Joyce or Duncan, would you like to unmute?
Good evening.
Oh, hi, Michael.
Yes, hi, good evening.
Go ahead.
Yeah, for me, from my side, I can say it has been a very interesting training. At least I've learned a lot and I've understood quite a lot, and especially with the challenges we are facing around with our patients. Actually, for me, working in the pediatric department, I've been having quite a lot of cases, and at some point we were not able to refer them simply because like the police are not supporting. But now with Dr. Omar having shed light on that, I think now we are going to sit and maybe have a way out on how we'll be able to be supported on the referral and probably help this patient, especially the pediatric population, to get some support. We even like currently we have a child in the ward, went for referral to Garissa, was seen, a biopsy was taken. I think it's about 3 weeks now. We yet don't have the results, and hopefully maybe this week we'll be able to get as we have been promised. Now from that, having gotten the results, for me thinking they could be positive of cancer, then what next? We might be tired and not be able to refer. But now, at least now we had Dr. Omar's, giving us a light. Maybe we can follow up that and maybe have that opportunity of referring the child. Thank you.
Yeah, I think it's a really good point. Sometimes when we don't have these kinds of calls, although Dr. Omar is very smart and extremely optimistic, I think, obviously I don't like to talk behind his back, but I think that the rest of us in the group know that the challenges are a bit more beyond just that. Now Garissa offers free cancer care. I think we all understand the refugee UNHCR system a little bit more than that, but I think it is really, even a year or 2 years ago, maybe we didn't have these options. So I think it's a really good point, Michael. Even with your current patients, hopefully, although maybe, obviously it's very sad if these particular patients may be not able to fully access it, but definitely trying to find ways we can make it work in the future. Michael, have you ever done any extra education on children's palliative care? Because there's a few different resources we can share.
Yeah, sorry, Erin, can you repeat the question?
Have you heard of children's palliative care? Did you know that people do specific palliative care for children?
Not yet.
Okay.
At least my first year.
Okay. So let's, obviously, most of you are on our WhatsApp, and I think I have everyone's email. I'll definitely be sharing around some resources. And yeah, there's some really interesting trainings that are available for free about children's palliative care, so I can share that around. You guys obviously are very busy, so I know you're not always going to have time to access different trainings, but if there's a specific need or a specific thing that you would like our team to look at, I think our faculty is willing to support you guys kind of ongoing. So please definitely keep in touch. Duncan, do you have any final comments, or Joyce or Hussein?
Okay.
Hey, Duncan.
Good evening. Good morning. Actually, the training was a success. I've gained a lot of knowledge. And many thanks to you, because actually you have been updating us, sharing the resources, keeping us on toes, so that some of us actually, it has made us to attend the session. Despite our working condition, I really appreciate the knowledge I've gained. I'm going to share with my colleagues. And I think the way forward, actually, I think now even the beneficiary will improve, will get actually what we have learned. The moment we practice, also they'll appreciate. And now I've also gained knowledge on how to pass messages and how to pass maybe a bad news to these people of concern. I've really appreciated a lot. And lastly, I was asking if maybe we can get a certificate for this training. Thank you so much.
Yeah, for sure. Yeah, I think we'll be sorting out the certificates. We did require that you come. I know, Duncan, you came many times. So usually we give the certificate based on attendance. I know we were a small group, so we should be able to share that in the next few weeks. I have created a final knowledge test. I know that this is not a university or college program, but we do want you to take it seriously. So the final test is a culmination, or I prefer to call it a quiz, I guess. It's a culmination of all 7 weeks. There's about 5 to 10 questions for each week. It is basic questions, and it is, we call it open book. So if you've taken notes, or if you've saved some of the presentations, you can go through the quiz and kind of answer it based on hopefully the information you've learned. I'll be sharing that around in the next week or so, and then you'll have some time to fill that out. Hopefully that will also be a good reminder of some of the topics we were learning at the beginning, because it's been a few months. But I'll be making an announcement through email and WhatsApp about that. But Tabello is our colleague and friend from the UK, originally from Lesotho, and she's starting a Project ECHO program just in a few weeks. Tabello, do you want to say anything to the team?
Oh, yes. I just want to say hello to the team, and what an incredible work they are doing, and under challenging circumstances. But it is an enormous pleasure to see how much effort they are still making to address the needs of those that are faced with the challenges, who have got so much extensive palliative care needs. So honestly, it's a great encouragement to hear what measures they are taking to address those challenges, despite all the dynamics that surrounds their delivery of care to those that are needed so much. So I think it is just encouraging for us to be able to learn so much from them. And as we can just take the knowledge and see how transferable it can be, even in our setting, because Lesotho, even though it's not having such dynamics and challenges that they might be having, but in one way or another, it's still another humanitarian issue of people that the whole country have got no access to this valuable care. So honestly, I felt there's so much transferability of their wisdom and their knowledge and the application of care that they do, that we can still learn from. So thank you very much.
All right, everyone, I think we'll finish there for today. We went way over time, but thank you for being dedicated. If you guys have a minute to turn your video on, I'd love to see you. This is our last class. It's probably not the last time you'll see us. But hi, Annalice. You guys have been a great team, and thanks for your dedication. I'll be sending around, bye Barbara. I'll be sending around the recording and just some follow-up, and we'll definitely be getting you your certificates. So thanks everyone. Have a good evening.
Bye.